So thank you guys very much for joining us today. We're really excited. I've been doing this a long time, and as a broker, I kind of get to see and feel the pain of our clients every year, just because the same old process and the same old limited strategies have been tried over and over and over. And so it's refreshing to have something new and something that I think actually addresses the issues that are causing the problems rather than window dressing. So what we're going to do is talk a little bit by way of introduction about the market, what's going on, what are the underlying causes of our issues with health insurance and health care. We'll delve into the big ones, the ones that are really driving it for employers, and talk a little bit about how health insurance has generally tried to work on this, and then describe what we're able to do with our health alliance that I think is going to be a real change. So if you have questions, by all means, use the chat, and we'll make sure and address those questions. And we have plenty of time, and it's 2020 and everybody's in a Zoom world, so don't feel like this is too formal at all. With that said, let's go ahead and move on. So you know me, or if you don't know me, my name is Cuatro Groos, and I earned that nickname because I'm Ernest the Fourth, and I was just flat numbered so they wouldn't confuse me with the other Ernest in San Antonio. And no, John JD DiMartino is not on The Bachelor, but we like to razz him because his wife chose that picture for him on LinkedIn. So he will not be giving a rose to anybody today other than his wife.
Cuatro, I'll put that rose away real quick, but thank you so much for inviting me onto this webinar. I'm really looking forward to walking through the product that you've built. And for those of you who don't know who I am, I'm from Plumdale Partners, and we're part of the team that Cuatro has assembled to create this program, the Forward Health Alliance, that we're really looking forward to talking to you about today.
Excellent. Okay. Well, thank you very much, JD. Pete, if you don't mind, Pete is at the helm with slides today. Thank you, Pete. We appreciate it very much. Okay. This is probably something that you're familiar with if you've been involved managing a health plan or involved with employer-based health insurance. And it's a little bit shocking to see it, but both for large and small employers, it's just been brutal. And this particular slide is going back 20 years, and we can see that in 20 years, the cost has actually quadrupled. And I know I've seen that in our clients, but I think it's a little more than that. I think there's even more challenges than what this slide seems to indicate. JD, what else is going on here that is problematic for employers?
Yeah, I mean, this is the chief complaint that we typically receive, Cuatro. And, we have right here a pretty smooth line with a pretty steady slope because we're taking averages. But one of the biggest challenges that our CFOs face year in and year out is that it's not a steady line. Sometimes It's a 5% if you're lucky. Other times I've seen as high as 150% increases at renewal time. And it's incredibly difficult to budget for your health insurance renewal. You hope that it's in line with trend. So if you're a CFO doing a forecast, you hope you can kind of budget to this slope. But that's been normalized, increases that are double digits year in and year out. So I think the problems that we have here is that this is normalized. This is expected. And for the most part, it's incredibly difficult to do anything about it, right? And in Cuatro, I think on the next slide, Pete, what do we typically do about this?
Right. So, this is the part that really drives me crazy as a broker. It starts, as you know, you're sitting there and you're waiting for your renewal, and you're waiting and waiting, and they only give you 30 to 60 days typically. So you might have been trying to have a budget. You might have been trying to budget for that renewal with no real idea what to plug in there. Surprise, surprise, it's a double-digit renewal. So out of the gate, the process has the employer already behind the eight ball. Next, what happens is the simple question: do we go to market? Do we not go to market? And Pete, if you can move that slide on or move it forward here. Yeah, so you go to market or not. Usually it's like we've got to try anything to try and get some competitive options to stretch our dollars. And so we're going to go to the same old carriers. We call them the usual suspects. So we're going to go to market, but you're really not holding your breath that you're going to get something great. If you move on to number 3, Pete, what's really happened over the last 10 to 15 years is that most brokers are bringing you the least bad renewal. And I'm no different. And that has been super frustrating to me because it really just feels like we're putting lipstick on a pig and we're trying to minimize the damage, but we're not excited about something good or better that we can bring to clients and to their employees and their families. And so that game gets very tiresome for employers and employees. If you move to number 4, Pete, invariably we get to talking about the cost shift. All right, is the employer absorbing all of this increase? Are we shifting some of the cost over to the employees? Are we making the benefits less rich to try and address all of this? So none of these are fun options. And that brings me to number 5, which is really our least favorite part of the job, where we're going to be the bearers of bad news. So we're coming to your employees saying, hey, here's your plan. Here's how this works. And invariably talking about, okay, here's where it might be costing you a little bit more. Here's where your out-of-pocket costs go up, et cetera, et cetera. And that just is a really tiresome process.
In Cuatro, it seems like every single year, you're paying more and you're getting less. And what you just went through and those status quo options have been absolutely devastating for employers and devastating for the employees and their families, right? And you can see this chart up here. When we take a look at what's happened over just the last 10 years, not even the last 20, there's been a huge run on high deductible health plans. So we've seen from 2009 to 2019, 162% increase in deductibles. We've seen a 54% increase in family premiums. We've seen workers' earnings only increase 26%, and overall inflation only increased 20%, right? And again, these are averages. There's some employers who are faring way worse than this, particularly now during COVID, right? So one of the most shocking things, in my opinion, that's happened is in 2019, medical debt became the number 1 cause of bankruptcy in the United States, right? And the first thought is typically, well, that's got to be because there's such a large uninsured population. 3/4 of those people had insurance, but their deductibles were too high and their earnings were too low. So they simply couldn't afford to flip the bill. So they had no choice but declare bankruptcy, right? And that is cognizant of really the type of pain that what's left of the middle class, if you can even call it that, is feeling, right? Those are the effects. And it's been, in my opinion, one of the most devastating blows to the middle class working American in the history of the United States.
Right. Absolutely. So JD, I'd love for you to introduce this next point just to help us understand what is this medical loss ratio and why does this matter?
Yep. So as it relates to insurance, just like anything else, we take a look at the insurance companies, and most employers believe that, well, these are the people that I'm hiring to run my health plan, but also these are the people that should be controlling my costs, right? That's who we're leaning on. That's who's negotiating with the doctors. That's who's negotiating with the hospitals. But one of the wacky misaligned incentives that exist, and Cuatro, we went into detail on this on the podcast, was something called the medical loss ratio provision. So when the Affordable Care Act was passed in 2014 or in 2010, most of the effects came into place in 2014. It was with the idea that we're going to get more people coverage. And, it's somewhat ironically named the Affordable Care Act, right? Because costs didn't actually go down for most people. And one of the provisions is what's called the medical loss ratio. So as Cuatro, you're going to explain in just a minute, that ties the amount of money an insurance company makes to the amount of premium that they charge. So the more premium they charge, the more money they make. And Pete, if you want to hit us with the first graph here.
Right. Okay. So we're using an example here. A company, an insurance company, is charging $1 billion in premium in 2020, and by law, they can have no more than 20% or 200 million of that premium going to their cost of admin and running their business, and they have to be spending that 80% chunk on direct payment of medical claims. And so if you click to the next one, Pete, what we see is if that insurance company was able to lower their premiums, the only way they would be able to do that is to have less claims. And ironically, with that deduction in claims expense, they're forced to reduce their take. So what we have is this really interesting disincentive by which insurance companies want to increase the size of the overall pie, which is the overall premium charged, in order to be able to make more money. And so this reminds me of going to a market and asking a vendor, what does this widget cost? And the vendor says, well, how much do you have? It's not at all logical. And I can't really think of other industries that are run this way. I think this is really the only one that I've ever seen, where the very design of it is set up to incentivize the wrong thing.
And Cuatro, I just want to add, it's not like this can't be done. When we take a look at Medicare and Medicaid, where the cost of services is fixed, the insurance companies scratch and claw for every last penny, making sure the costs are as low as possible so that the premium that they're making, they can maximize that revenue. So it's not that they can't do this. It's just that there's no incentive to do this in this model right now.
Right. All right. This particular chart is interesting to me because this is a look at the hospital systems in Central Texas. And it's a look at cost, what's billed, and quality. And the quality line is that sawtooth looking line that runs through it. What I find fascinating is that the cost and what's billed vary wildly, right? And in fact, you see what's billed is so incredibly high compared to the average cost. And this is the second example of the concept we just went over. When insurance companies in the fully insured world are negotiating with PPO networks, in order to be a network provider, they negotiate a percentage of discount off of their rate. Now, they're not negotiating a top rate or a ceiling or the worst case cost. They're just negotiating a percentage off of that cost. So obviously, what's going to happen is a hospital knows, as an example, if they simply dramatically increase the cost they charge, their percentage take in their network is going to be higher. And it's really borne out on this chart. You just see it across the board. But the quality doesn't necessarily track with the pricing. And that's, to me, is one of the biggest issues. I once insured a company that was a think tank, and they were really pushing on a business model of helping to measure the cost as well as the quality for healthcare providers. And in the Dallas-Fort Worth area, they got all the hospital groups to agree to share their data on outcomes, on pricing, on everything. And when they released their first study, which was on what's happening with double bypass heart surgery in the Metroplex, lo and behold, the hospital with the best outcomes happened to have the lowest cost for double bypass surgery. And almost immediately, all of the hospitals pulled out and said, we can't share our data with you anymore. And this startup actually had to pivot and change to a different business model altogether because they quickly learned that that wasn't something that the medical providers wanted consumers to know. And that really is at the heart of what we're up against. And that's why me messing around with your copay or how much you charge, how much you have your employees pay towards their own health insurance doesn't impact this one iota.
And Cuatro, I would add, you refer to these patients as consumers, and even that term, right? In order to be a consumer, you need to know cost and you need to know quality. But if you call any hospital and ask them how much something costs, you're not going to get a straight answer. And if you call them back 4 or 5 times, you will still not get a straight answer. The only thing that those calls will have in common is that you'll end up just as confused each time after each touch point with that hospital. And it's not just hospitals, physicians, I mean, you name it. It's very confusing. And it's confusing somewhat on purpose, right? And many times the person that you're speaking with, they genuinely don't know how much something is going to cost, right? Because oftentimes they don't even know the billed average. They don't know what the starting price is, and they don't know what the discount is for the PPO network, right? And if you ask a doctor whether or not they're a good surgeon or not, what do you think they're going to say, right? And there's not really great databases that are available to the public that have that information. So it's almost impossible to shop around and be a consumer of healthcare.
You're right. And the major carriers have tried to have some information available around quality of providers, but they really make you work for it, and it doesn't at all speak to cost. So, I think the baby steps we've seen just aren't even close to enough given the challenges for our consumers.
Yep.
All right, Pete, let's see. Okay. So you're all probably familiar with the Pareto principle, the 80-20 rule. 20% of, in this case, medical claims driving the wagon, driving the remaining 80%. And really what we're seeing here is that 80-20 has become 90-10 or maybe even 95-5. And that's a big problem. But I think an even bigger problem has to do with catastrophic claims. And, JD, that's something that you've probably seen a lot in recent years in terms of what's happening with catastrophic claims and how they impact the overall picture.
Right. In Cuatro, we have a ton of data and very robust data analytics programs that most of our clients utilize. And what we found is that both the frequency and severity of high cost claims is increasing, right? If you go to the doctor, maybe it costs $150. But if you happen to have a rare disease, that potentially could cost $1 million, $2 million, $3 million for total treatment. And one of the examples that I use is hemophilia. On average, cost about $1 million per year. And if you're the health plan, or in this case, the employer forking the bill, you're paying for that, right? And one of the great things about the United States, and one of the great things about the innovations in medical advances, is that they're coming out with something that is pretty close to a cure for hemophilia, which is awesome. That's excellent. The problem is it cost $3.5 million to get this drug. So health plans are struggling to figure out how exactly they're going to allow patients to go after that drug, right? And that's one of many examples. There's drugs called biologics, which are specialty drugs that are coming out, and they are what's called a specialty drug, and they typically come with a huge price tag, and they're typically for things like cancer treatments, for example. And some of the ones that have come out, between the actual drug itself and the intervention between a medical staff, a surgeon, and actually giving them the drug, can cost anywhere between $3 and up to $5 million in total intervention. So those things do happen, and they are happening more frequently, right? So when we're talking to employers and CFOs, that is one of the things that keeps them up at night. Is one of my employees going to have one of these types of claim events? And if so, how are we going to be able to afford it, right?
Absolutely. And it just doesn't feel like our system has kept up with the pace at which these new technologies, particularly in biologics and particularly in pharmaceuticals, have been occurring.
Mm-hmm.
Pete, if we'll go to the next one, this next pie chart that you're seeing right now, I think is hugely important, and it's really just the average of cost for each of the components of healthcare that members experience. And JD, I'd love it if you could talk a little bit about what you feel like is the important takeaways from looking at this chart.
Definitely. And we're peeling back the layers a little bit here and showing you kind of where your premium dollars go, right? Pharmacy, inpatient, outpatient, physician. And when we're taking a look at this, pharmacy is the fastest growing one. In many instances, it's anywhere between 20 to 30% of total spend and continues to grow, mostly due to the cost of those specialty medications and changes in the way brand and generic drugs are being treated. But when we take a look at these things, going to your physician for a one-off visit here and there, which everybody should be doing at least once a year for their annual checkup, those types of things are nickel and dime, but they're frequent, right? So you can see that that's a pretty big piece of the pie. And for the most part, there's not a ton you can do about that. But when we look at pharmacy, when we look at inpatient, and when we look at outpatient, with the exception of emergency room, all of those other things we can deal with in a variety of different ways. On the pharmacy side, we can optimize a contract and we can lower that by as much as 30 to 50%. And on the inpatient and outpatient side, like you mentioned, and as we're going to talk about in just a minute, almost all of those things have to go through a prior authorization. So you need to check with the insurance company before you get that knee surgery, that elbow surgery. And in the next few slides, we're going to talk about the ways in which you've built this plan to help get better outcomes for the employees, which, as you mentioned earlier, typically yields a lower cost.
Absolutely. So what you see right here is really a look at what are the pieces that go together to make a health plan. And most small employers to mid-sized employers are really using just a typical fully insured health plan. And you know what you get, what your employees are dealing with co-pays and out-of-pocket costs. They get their insurance card. You pay the bill. That's it. You leave it alone. You don't really know what's behind the curtain. But if we peel back the curtain, these are the components that go together to make that health plan run. And what we've decided to deal with is let's actually take each component and make sure that we're getting the most out of it, that it's the best of breed as far as who's providing the service, that the contractual terms are favoring our employers and their employees. And really, so many times what we find is that these things are not designed with the interest of our client in mind. And the fat of excess cost that's left there to benefit providers along the way or middlemen in this chain never seems to reach our employer and their employees. And that's really been the big driver behind our desire to change the game a little bit and make sure that this becomes much more customer centric. And that's really at the heart of this.
And Cuatro, I wanted to add, this is what you and I have been working on over the last year, is taking a look at each one of these component pieces and vetting out a best-in-class vendor. So, for example, TPA administration, that's the organization that pays your claims. Blue Cross Blue Shield has them, but there's also 180 other organizations that do a wonderful job at paying claims. one of the small differences between the two is they simply audit the claims. And you may be thinking to yourself, well, doesn't everybody audit the claims? But no, there's something called auto adjudication, where anytime a claim comes through, as long as it has the appropriate information, they just pay the claim. Nobody actually looks into it, right? Which again is because they want to pay more claims, right? But that doesn't do the employer any good. So that's just one piece where we said to the vendors, you have to audit the claims. That's going to be a huge part of the way in which we run this organization and this Forward Health Alliance. And then we're going to talk about a few more of these in a little bit more detail. But I think the big thing that we want to make sure everybody's aware of, we've broken these down into the component pieces. We've vetted out best-in-class vendors, and then we've integrated all of them to create a proprietary program that is the Forward Health Alliance, right? And what that program is designed to do is it's designed to be transparent. And to you, the employer, that may or may not matter too much, but to Cuatro, who's proactively managing the program, it's absolutely essential because through transparency, access to the contracts, data analytics, and oversight, that's going to drive accountability. So if any one of those vendors is doing something that they're contractually not supposed to do or isn't compliant with the contract, we can intervene. When you're direct with a fully insured carrier, we have no idea, honestly, what's going on behind the scenes because we don't have access. And what that's going to allow is a lot of control. So that way, year over year, the program can be proactively managed, and it's going to allow for a ton of flexibility. In Cuatro, over the last 3 to 5 years, the amount of innovation that's taken place in our health insurance space has been almost unimaginable. Right. So as these new products and new vendors come to market, this program is going to be able to integrate the ones that we think are really going to make a big difference. And that, I think, is absolutely huge for the employers that are going to be a part of this.
Definitely. I think it's worth making sure if you're hearing us talk about this, we want to be very clear. We don't want any solution that we try to suggest to involve more work or confusion for employers or for members or for employees. In other words, what we offer has got to be simple and just plug and play, easy to experience. Because what's come back from focus groups and conversations and research is a clear message of don't ask me to become expert in this industry just to administer this to my employees. And employees don't want to have to go searching every time they need an answer. So with that in mind, I want to describe a little bit about what drives our ability to put this type of plan together the way we do it. And it's self-funding. Now, self-funding as a term often scares small to mid-sized employers because they think, oh, that's for the biggest people out there. I can't afford that. It puts me at great risk, or I don't understand it. And really, in its most simple form, what we're talking about is actually self-funding, but re-insuring your risk. And the idea is simply that I know how much risk I can tolerate. And beyond that, I want somebody else on the hook for it. And oddly enough, about 97% of large employers are leveraging self-funding strategies. And they're doing that because when they reinsure their risk, that network is nothing more than a network. And at the end of the year, if they haven't had high claims, instead of that just being pure profit for an insurance carrier, that's money that's back into their coffers, invested back into the business to grow the business. So you really do become the master of your own domain, and you get the benefits instead of somebody else in this chain. And what I find most interesting when I talk to employers who are just simply fully insured, or maybe they're on what's called a level funded plan, they're feeling like, hey, this is all I can do. I can't afford to go find reinsurance. And what's fascinating is your carrier who's providing your insurance, they're reinsuring their risk. They don't even pay all of the claims for your employees and their families. They only pay up to a certain amount, and then somebody else is on the hook. And so the question comes back, if it's good enough for 97% of large employers, if it's good enough for your own insurer, why wouldn't this be good enough for you? And really, we're trying to make sure that this approach, which allows us to take control of each aspect of the plan and demand a better deal, is really a no-brainer. Once employers get into this model and they stay with it for a few years, they rarely leave it because it just makes sense. And we talked a little bit earlier about the pharmaceutical side of your healthcare. And a plan has what's called a pharmacy benefit manager. We're going to talk in a few slides here about that particular aspect of this and just how much we're able to save clients by controlling the terms of the deal to put it back in their favor.
Absolutely. In Cuatro, that the message that I hear loud and clear is you build the custom health plan, and the only way to get access to that is to self-fund. But self-funding can be a little bit scary for smaller employers. So you've designed a program that allows them to safely self-fund, right? And then what we're taking a look at, I'm going to take a look at the bottom left-hand corner here, simple for members, is we're not getting wild with this. This isn't a reference-based pricing program, although it could be if an employer so desired. It has a PPO network. Employees are going to have access to just about the same doctors, hospitals, and facilities with either the Aetna or the Cigna network. They're going to have the same level of copays, deductibles, co-insurance. They're going to have a huge pharmacy network in a very broad formulary. They're going to have access to pretty much all of the same drugs, all of the same doctors, all of the same hospitals. So in this program, the disruption to the employees is almost zero. It's the same disruption you'd have from going from Aetna to Blue Cross Blue Shield, right? On the right-hand side, simple for employers, we understand that employers are typically coming out of either a fully insured program or a level funded program. And what they're used to doing is paying their monthly premium and then not worrying about it again until they have to pay next month's premium, right? And then the big worries come at renewal time, which we'll talk about. But that's the experience that most employers have. In a self-funded program, you can have a much different experience. But the way we design it is that each employer, just like with the fully insured or level funded program, has an annual maximum and has a monthly maximum. So just like with the fully insured program, all they have to do is pay that monthly premium, and then they don't have to worry about it until it's time to pay the next month's premium. Now, behind the scenes, Cuatro, I know you're doing a lot of work. You're looking through the data analytics, you're picking up on trends, and you're working to proactively manage the health plan. But that falls on you. For the employer, all they need to do is work with you during the transition, pay their bills on time, and then you and your team are doing the rest.
That's right. And we've never had the ability to really get under the hood with the data we needed on what I'm going to call off-the-shelf plans. I like to use the analogy of buying a car. If in the early days you went to buy a car, you didn't get a choice. You got a Model T, and the Model T was what it was. It was any color you want, as long as that color is black. And there was no option for components, and that's really what's happening with most small and mid-sized employers. When they get their health plan, they don't really know if their carrier is good at all of the aspects of the health plan. And they certainly don't know, well, in which of these elements is the employer really making their money? They have no idea. We're able to take a lot of control and be able to not only negotiate really great up front to make sure that it's as low cost as possible, but manage it ongoing with real-time data to find patterns, to impact employees for their benefit and for the benefit of the overall plan. And you just can't do that with off-the-shelf plans.
Right. So you're telling me I can get a blue car if I want now?
You can get a blue car. We can do a
And Cuatro, when we're talking about the results associated with the program that we've built here, and this is without you looking at the patterns, this is without any proactive management of the health plan, divvying it up into a few different buckets. When we're looking at just the medical claims, doctor's visits, outpatient, inpatient, on average, we're seeing a 10% savings by switching to this model, right? Again, with no management and no intervention. On the pharmacy side, we have a very robust, optimized contract that has best-in-class terms, conditions, guarantees. For those of you who have heard about rebates in the news, we pass through 100% of the rebates. And because of that, on average, we're saving at least 30% on the prescription drug claims. And then the next two buckets, the admin fees and the reinsurance fees, we're squeezing them as well. And albeit they're a much smaller part of the healthcare dollar, but we're saving anywhere between 10 to 25% on those pieces as well. So overall, we're lowering the cost by as much as 20% just by jumping into this program. And while we're doing that, we're simultaneously working to enhance the members' experience, which we're going to talk about in just a minute. Cuatro, my favorite part about this slide, aside from the mask on Mr. Ben Franklin, is the fact that it's supposed to be a healthcare dollar. And unfortunately, there's no such thing as a dollar in healthcare. So it's represented by 100 instead.
Yeah, the Ben Franklin slide, my favorite by far. All right, so, that's the guts of the plan. That's how we kind of put the thing together and try to negotiate better terms. But beyond just dealing with the financial side and lowering costs, the goal is also that we need to make things better for our members. We're actually trying to help them be healthier and minimize not just their cost, but minimize the churn, the frustration, the difficulties they may be having. And so I'd love if you could, JD, to just speak to a couple of these elements here.
Yep, and Cuatro, we're going to dive into these a little bit more on the next few slides. But really, we talk about health insurance all the time, but what we never talk about is health care, right? Because health insurance is just a financing vehicle. It's the care that the employees are receiving that really matters. Right. And we've kind of intertwined those two, and not us, but the industry at large. But we need to set up some sort of advocacy program for the members to make sure, like we mentioned earlier, that they're accessing the best care. They're accessing high quality doctors. They're going to the physician or the surgeon who has the best outcomes. And we know when you do those things, it happens to cost a little bit less too. And in some cases, it happens to cost a lot less, right? And when you talked about insurance protection and reinsurance, we have to have the right insurance protections, right? So we have to have a specially designed program that allows the employers to have an annual max and a monthly max in the same way that they do now. And it also has to allow, just like on the fully insured market, the ability to spread risk, right? Because in the event that one of the smaller employers does have a catastrophic event, we don't want their premiums to increase by 50%, right? We want them to be as close to trend or below as possible. So by combining forces with other small employers, we're going to achieve that scale. And we'll talk about that in much more detail. And then finally, like we talked about a few times, we really need insight. We need data analytics, and we need to be able to proactively manage the health plan. And the only way to do that is to have data. And for those of you on here who are Texas-based, you may be familiar with SB 2015, which does provide some data, which is much better than nothing. But that's the tip of the iceberg compared to the data that we need in order to fulfill our duties as consultants. So I saw somebody pop up there. So along those lines, we're looking to really get in the weeds with some of these details, again, so we can enforce the accountability, take control of the plan, and make sure that all of the vendors are doing what they need to do. So this is probably the core tenet of this program, right? So building the health plan, self-funding the benefits, those are the two pieces that really make the program special. But what sets it apart is the protection that's provided by pooling risk. So when we're looking at textbook what size does an employer need to be in order to self-fund? Textbook historically has been about 500 employees. Although recently, due to advances in technology and underwriting and algorithms, at 300 employees, you can typically safely self-fund. But what about the smaller employers, right? And why 300 or why 500? Well, in order to safely self-fund, obviously you need reinsurance protection, but the actuary, the person who's setting the rate, needs to be able to accurately predict how much we think you're going to spend next year in claims, right? And that's a function of the law of large numbers. The more data points that you have, the more likely you are to be able to find a pattern, right? So we need to have data points. So you can have one 500 employee employer, or you can have 10 50 employee employers, right? The data is going to be the same, and you're going to achieve the same result. That is, you're going to be able to allow that group to safely self-fund the way that those larger employers are able to safely self-fund. And when you have that group of small employers, it provides us with leverage when negotiating with the stop loss company. So we can set that annual maximum and that monthly maximum. It's going to allow us to smooth out renewals. So in a fully insured program, if you have a bad year, you could get a 50, 60, 80% increase, right? In this program, if you have a bad year, we expect that 1 in 3 or 1 in 5 years, you're going to have a catastrophic event. So we're going to smooth out that renewal. So that way you're not going to get whacked with a 50% renewal just because you had one bad year. And Cuatro, the biggest component of this is what it allows us to do, which is it allows these groups, these employers, to enter this program and stay in it for multiple years, because we're not shopping insurance companies anymore. What we're doing is proactively managing the health plan, allowing them to stay put, and allowing us to mitigate risk and deploy some cost containment strategies to help make sure that year in and year out, their renewals are very favorable. And that if we budget for $1 million of premium and we only spend $600,000, then the employer keeps that $400,000 delta. That's really what we're trying to achieve by pooling risk and self-funding. And I think that is extremely important that the people on this webinar understand that this allows them to safely self-fund.
Definitely. I think that, that for our clients, they just need to have a level of confidence that that's going on. That's not something that they're necessarily going to see or that they're going to experience. That's the minimum we need to do to be able to do a better job advising and managing and refining the plan. What we see here is really the stuff that people experience on the customer end of all of this. And, advocacy is a big, big part of it, because usually our clients feel like they're kind of on their own when they're dealing with health insurance, when they're dealing with health care, when they're dealing with navigating the maze that may just be one surgical experience. And so I think it's kind of important that we understand what is it we can do and why is it better than maybe what people have been used to.
Right. And I used to joke, Cuatro, if you go to an open enrollment meeting and ask the employee population to raise your hand if you're confused by your employee benefits program, I mean, absolutely every hand goes up, and a few of them are waving it around like crazy, right? Because it is a truly perplexing experience being a patient in the healthcare system, right? And what we know from wellness programs, and I say this only half facetiously, is that employees really don't like to do things on their own. And whether it's a carrot method or a stick method, they would prefer that somebody else help them along the way. And I totally understand that. I'm exactly the same way. So when we created this program, we wanted to say, okay, listen, if you're an employee and you need care, or you need to see a doctor, or you're just a little bit confused about your deductible, copay, or coinsurance, call the employee advocate. This is somebody who's familiar with your benefits, somebody who's been trained to assist you navigating the complexities of the healthcare system. And this is someone who's going to steer you towards that high quality doctor, like we talked about a little bit earlier. So whether it's general questions or a second opinion for a diagnosis, and Cuatro, this is extremely important. The Mayo Clinic did a study, and they found that 90% of the time when somebody gets a second opinion, the diagnosis is changed in part or in whole. Right. And one of the big reasons for that is if you go to a surgeon because your knee's bothering you, they look at it with a surgical mind and they say, I can absolutely fix this problem. Let's get you on the OR table. We'll snip around and you'll be good to go in a week. But that tends to be a little bit more intrusive than, say, physical therapy, right? Where you might be able to achieve the same clinical outcome. It's just you have to go see a physical therapist, 3 times a week for the next month. And I'm not saying one is right and one is wrong. But what I am saying is the patient, in this case, your employee or one of their members, their dependents, should be able to know that there's a couple different options that exist in the marketplace and then choose the one that's right for them and their family. And maybe it is surgery, but maybe it's physical therapy instead. And if they're having issue with lifestyle or productivity issues, or if they're having trouble managing their diabetes or trouble getting their insulin or whatever it may be, the advocate is there to assist them and make sure that they're navigating the healthcare system in a way that's easy, in a way where they're going to get the best care possible. And we do that because we have access to billions of claims per year. We have over 18 unique data sources. And we have a ton of different quality metrics for doctors and hospitals, physicians and surgeons all around the country. Things that the layperson doesn't have access to, and things that even if we gave them access to, they probably wouldn't use, right? So they can just pick up the phone, call the advocate, and they'll walk them through all of that, figure out what their unique needs are, and set them up with a physician, a doctor, a surgeon, a hospital, whatever it may be, that's right for them.
Definitely. All right, Pete. So what we see here, we've covered in pretty good detail transparency. We've covered how this is done, the performance of the plan. We've talked about how we're able to take a real level of oversight that you just don't normally have in order to impact the plan. It's the bottom right corner that I want to draw your attention to, sustainability. And that's important because as a broker, I would love to believe that my clients just love to see me and they just love to go to market every year and talk about health insurance quotes and changing carriers and changing networks and all of that. But the truth is they would love to have something that simply works and that can run for many, many years. And so the mindset of the kind of employer who may be right for this program is, I want to come at this with a multi-year strategy, and I want to be able to manage this, and I want to lower my cost curve. And moreover, I don't want to have to change the entire plan and every aspect of that plan if I'm dissatisfied with performance of any one element of the plan. And we like to tell clients that in a 5-year span, they're probably going to have one incredible year with really, really low claims. They might have one really tough year where they might have high claims. And then there's going to be a few years in the middle. And when you're on a fully insured health plan, by and large, the 5-year span is very profitable, just not for you. It's profitable for your carrier. And when you're in an arrangement like this, what ends up happening is that 5-year span really kind of shows you how much better for your bottom line it can be. And you just want to keep going with it because this is a lot easier for the employer to deal with year in and year out. It's a lot easier for the employer to make budgeting decisions with because we'll have a lot richer data and we'll be able to have that conversation earlier in the process to give them a better idea of what they may need to budget for. And the thing just works.
In Cuatro, I'll say the conversation's a lot different, right? It's not, you're looking at a 20% renewal this year, what carrier is going to buy the business? It's, these are the 3 or 4 things that we did for you throughout the year to proactively manage the health plan. Here's what the ROI was. This is what your budget is for next year. And here's 3 or 4 suggestions for the next plan year that you may want to implement to help contain those costs or enhance the member experience. And it's not totally uncommon in a program like this to actually increase the level of benefits because the plan's performing so well.
Definitely. Pete, if you'll move along, thank you very much. So we've got a few little tiny case studies here that speak to kind of how this can work in different industries. And I want to point out that we're not trying to make anybody think, oh my gosh, I saved, 1,000%. We want to be realistic, but it's important to understand that if these people or these groups started in 2016 and 2017, and in each of their cases, by the time they're at 2020, they're spending less than they were in 2017. Even if they were spending close to the same amount as they were in 2017, that's a huge win, because what we're used to in the marketplace for small employers for health insurance has been that 1% of increase 5 years ago is so much more exaggerated when you talk about 1% of increase now. And this incredible steep curve year after year after year is really what drives employers crazy. So the ability to roll back the clock and stabilize that cost curve is really why people gravitate to this type of strategy.
Mm-hmm. And Cuatro, compounding interest is great for stocks, terrible for health insurance. Right? And we chose these three because they were three that had a very similar program to the one that we just described. But these weren't very proactively managed the way that Cuatro and his team are able to manage. This is just, we set the program up and let it run, right? So these are not the most astounding results we have. We can show you 50%, 70% savings versus 3 years ago. But the other thing that we wanted to show in here was the PBM repricing, right? I said earlier on that we've optimized.
PBM, remind us what that acronym means.
Yep, I jumped ahead. That's Pharmacy Benefit Manager. And for most employers, they have no idea who that is. But typically, there's three of them that 76% of Americans have: Express Scripts, Optum, and CVS Caremark. And those are the entities that process all of your prescription drug claims. And they're always integrated into your fully insured or your level funded program. You may even have an ID card that says CVS or Express Scripts or Optum on it. And what you need to know is that the amount that you pay for your prescription drugs has to do entirely with the contract between you, your insurance company, and the PBM. Some PBMs have very competitive contracts. Some have not so competitive contracts. But one of the things that makes this program very unique is that the contract has been negotiated by our team and by Cuatro's team, and we've optimized it to get best-in-class terms, conditions, guarantees. And without going too far down that rabbit hole, because we could do a whole nother webinar, probably 5 to 10 webinars on just PBMs alone. What we want you to know is that we've done that. We're leveraging our data analytics platform to make sure that those contracts are being enforced. And you can see below the type of repricing that we typically see when you're coming out of a fully insured or a level funded contract. And as you can see with Optum, Express Scripts, and in this case, Welldyne, we're showing anywhere from 44 to almost 46% savings. So when we took a look at that healthcare's big lie slide, and the cost of prescription drugs on average per person or per health plan was about $4,000 per person. Imagine just chopping that in half and taking that to $2,000, right? That's a pretty big chunk right off the bat that we're saving these health plans. So that's one of the contracts that we've optimized. We've optimized many of them, but that's one of the ones that's easiest to show because we can run the numbers and provide the savings right there.
And I think it's one of the most important ones because without question, the increases in cost in the pharmaceutical world are the biggest driver of health insurance premium hikes. So this is where I want to make the biggest bang is to really cut the fat off of this element in the chain. All right. So this brings us back to the original image, the original chart. And really the question is just simply, have you had enough of this? Because as a broker, I know I have, and I'm really tired of building spreadsheets that just stay so superficial that we're not really impacting the things that drive problems. And if you've had enough of this trend and you think you want to explore something a little bit different, we would love to talk to you about it. And with that, I think we'll open up for any questions anybody might have. I know one question that I got sent earlier was, with this program, what are the networks that are used? Like, what would be the network that members would be on?
Yep, and that's a great question. So in this program, we have Cigna and we have Aetna. And around the country, there's some smaller specialty networks as well. But one of the things that makes a TPA, a third-party administrator, or a claims payer, and I mentioned that there's 180 of them outside of Blue Cross Blue Shield, United Healthcare, Cigna, and Aetna, that makes them really unique, is that in the event that somebody's doctor is out of network, they can always strike an independent deal with them, right? Which goes back to the control over the health plan that we talked about. So even if there's a little drop off in network, and there always is, going from Aetna to Cigna to Blue Cross Blue Shield, we can help fill those gaps over time by negotiating proprietary or direct contracts with those doctors, hospitals, et cetera.
Great. Okay. Another question that I got was, what do you need to do if you are interested in this? What type of information do you have to provide, or how do you go through the process of underwriting for something like this?
So the process is not too dissimilar from anyone who's gone through a process, maybe moving to a level funded program, right? So we'll need a census. We'll need the plan information. If we have an SB 2015 data report, we can work with that. If you're level funded and you have access to additional data, we'll take that. And oftentimes that's all we need to at least get started. But in the event that we don't have data, one of the things that makes this product special is that we don't just let anybody in to the pool, right? We want to make sure that the risk that enters the pool, and I know that's kind of a consulting way of thinking about people, but we want to make sure that the integrity of the pool is maintained. So if there's a group who has, $1 million in premium, but $3 million in claims, that's somebody who won't be able to access the pool, right, until their claims die down a little bit. So along those lines, we will request individual medical apps called IMQs. And that's a pretty simple program. Cuatro, you'll send it out to the employer via email. They'll disseminate it to their employees. And all the employees have to do is click a link, fill out their information. Takes about 5 to 10 minutes. And then from there, we're collecting all the information that we need, and we can go through the underwriting process and issue what's called a firm and final rate, which means a guaranteed rate for that employer.
Got it. Now, we're all in this pandemic, which means there are a lot of people are working from home and working remote. It's kind of the age of Zoom right now. And so for a lot of people that are managing HR and dealing with things like open enrollment, it becomes vital to have an efficient electronic process. So, talk a little bit about how enrollment into the program happens for the employees.
Mm-hmm. And Cuatro, there is no shortage of benefit enrollment systems that exist in the market. I know that you have access to a handful of them. Our team has a few more as well. And some of the employers who may have ADP or Paychex or one of these other payroll systems may have their own Ben admin system. But the idea is we can use any enrollment system because what they do is they always spit out an Excel spreadsheet when the enrollment's completed. and then we simply upload it, to this case, to the third-party administrator, and then they upload all the information, and then typically in less than a week, they're ready to generate cards, send them out, and get everything rocking and rolling. So if there is an electronic Ben admin system available, we can integrate with it. That's the long and short of that one.
Yeah, and that becomes important. And we've reached a point with our clientele where paper is dead. Nobody wants to deal with it. A lot of the time you hire an employee, and if you mention fax, they say, what's that? And so really we've come to this place where everything needs to be electronic. And so we have Ben admin systems available to our clients. And then we also advise them when they're using platforms that might also include those that are tied to their payroll. I don't think I see any more questions. So what we may do is, if you've been listening and you think of something that you want to ask later today, tomorrow, next week, don't hesitate to reach out to us. We're more than happy to talk. We want to make sure we're making great use of your time. So we'll be very careful up front when talking about this to make sure that if this really seems like it might be right for your company, we'll help you through it. But we don't just want to throw at anyone or everyone at this. As JD mentioned, what we really want to do is be careful about the employers that are part of this and that get into the program and manage the program so that everybody benefits down the line. And we're really, really excited about it because in 2020, I feel like there's just not enough lipstick for all the pigs that are these normal renewals for all of these insurance plans. So I'm thrilled to have a different conversation than the old one.